Welcome everyone to today's presentation, Uterine Fibroid Embolization with the Magellan Robotic System. Our presenter today is Dr. Keith Sterling. Dr. Sterling serves as Director of the Department of Cardiovascular and Interventional Radiology at Inova Alexandria Hospital. He has been consistently recognized by his peers as a top doctor in Washingtonian and Northern Virginia magazines. Dr. Sterling treats a wide variety of medical conditions and diseases with minimally invasive techniques, reducing pain, risk, and recovery time for his patients. And he was one of the first in the country to perform non-surgical, robot-assisted uterine fibroid embolization procedures with the Magellan robotic system. Thank you for joining us today, Dr. Sterling, and I will now turn it over to you.
All right, thank you very much, Brian. I really appreciate the opportunity to talk to the audience about a topic that I'm very passionate about. So we're going to get right into the talk now. What I'm going to do today is I'm going to talk about what are uterine fibroids. I'm going to talk about the symptoms that they can cause, as well as the diagnosis of fibroids, different treatment options, and also what's new in uterine fibroid treatment. So first I'm going to get into what are uterine fibroids. Uterine fibroids are benign tumors of the uterus. They are the most common pelvic tumor in women, and they're very vascular tumors, and that's going to make sense a little later when I talk to you about uterine fibroid embolization. They are not considered precancerous or malignant in any way, and they're referred to, besides uterine fibroids, as myomas or leiomyomas. So here on the left we have a picture of the normal female pelvis. There's the uterus and the ovaries on either side, and the uterus is generally a very small organ of the female pelvis. As far as fibroids, if you look to the right, fibroids come in a variety of locations, and they can either grow out from the uterus or they can grow on the inside of the uterus or right in the middle of the uterus. And where the fibroids are located can frequently correlate with the exact symptoms that women can have from their uterine fibroids. And so here is a list of the symptoms that uterine fibroids can cause. Most commonly heavy, prolonged menstrual bleeding, or pain and pressure, or the feeling of fullness in the pelvis, abdomen, or lower back. If the fibroids press on the bladder, they can cause urinary frequency or the urge to urinate. They can cause constipation, pain related to intercourse, just in an abnormally enlarged abdomen, and they can also be associated with either infertility or miscarriages. Uterine fibroids, as I said earlier, are very common, and the lifetime risk for all women is somewhere between 70 and 80%, and the incidence we see can increase with age, where you can have about 40% of women who are in their 40s who have uterine fibroids. We don't know the exact cause of the uterine fibroids, but we know that there's a genetic predisposition, that they are more common in African American women. We see that they run in families as well. We know that although uterine fibroids are very common, less than 50% of women are actually symptomatic, and only about 20% require treatment. However, in the United States alone, there's greater than 650,000 hysterectomies or myomectomies. Myomectomy is the surgery where just fibroids are removed, not the whole uterus, are performed annually in the United States. And of the greater than 400,000 hysterectomies performed in 2010 from this one paper, approximately 50% of them were for uterine fibroids. So that's still a very common surgery performed for women with uterine fibroids. As far as diagnosis, most commonly it's diagnosed on physical examination. During an annual visit, the gynecologist may tell a woman that they can feel that the woman has uterine fibroids. And then the first exam that's generally performed to confirm that is a pelvic ultrasound, and that can be performed either with a probe on the woman's belly or using a vaginal probe. Some people will have a CAT scan for a completely different reason, say for example for pelvic pain, and the uterine fibroids will be seen on that CAT scan. MRI is an excellent tool being used for diagnosis, but a lot of times we use it once we already know a woman has uterine fibroids and we're trying to make treatment decisions. And then there's hysteroscopy, where a scope is put actually into the vagina and then through the middle part of the uterus to look at the uterine fibroids, or laparoscopy, where a scope is put in through small little incisions in the abdominal or pelvic wall to look at the fibroids from outside. As far as treatment go, most women, as I said earlier, are asymptomatic, and they don't need any treatment, and just basically surveillance either with follow-up pelvic ultrasounds or just physical examination is all that's needed. Sometimes patients will require treatment, and the first line of therapy is generally medical therapy, and that can include hormone-based therapy such as birth control pills. If women are having cramping or pain, sometimes non-steroidal anti-inflammatory medications such as ibuprofen. Some patients are anemic and therefore they need iron supplementation, and then a variety of other multivitamins and homeopathic medications have been used to treat minor symptoms. And in many patients, when symptoms are controlled with medical therapy, no other treatment is needed. Sometimes hormonal therapies will have side effects that women cannot tolerate, or there are other risks when being on certain hormonal medications long-term, so it's really, they're generally just used short-term. And a lot of times when hormonal therapy is discontinued, the fibroids that may shrink as a relationship to that hormonal therapy, they will grow back. So if women don't tolerate or don't have a successful outcome from medical therapy, then we talk about actual treatment options which are a little more invasive. So I'll run through a bunch of these. For women who are having heavy menstrual bleeding from their uterine fibroids, sometimes an endometrial ablation where the lining of the uterus, the inside lining of the uterus is cauterized, and that could be done with a standard electrocautery, but can also be done with certain devices, one called the NovaSure device and the other is a ThermaChoice balloon, and there are a variety of others also, but the whole idea of that is really to be used in women who are having heavy menstrual bleeding. The issue with that is certainly in women who have an interest in future pregnancies, really they can't get pregnant after that because it does destroy the lining of the uterus. There is also a technique called MR-guided high-intensity focused ultrasound, and generally that's where a patient is on an MRI machine and very high-intensity ultrasound energy can be penetrated through the abdominal or pelvic wall to ablate or destroy the fibroid. The issue with that is generally it can take many hours to just one fibroid, and it's not widely available, and there is no, currently there's been no insurance coverage for that procedure. Another option, and probably the most common options, are surgery, and that includes myomectomy, which again is removal of the individual fibroid or fibroids, or hysterectomy, and those surgeries are most commonly performed with an abdominal incision. However, they can be performed laparoscopically or hysteroscopically assisted as well. And then we're going to come to uterine fibroid embolization, which is the one that I'm going to talk about that's performed not by a gynecologist but actually an interventional radiologist. Uterine fibroid embolization, known as UAE or UFE, or fibroid embolization are different terms you'll hear this procedure called. So this is performed by interventional radiologists. We are minimally invasive physicians who perform these targeted therapies, and we actually do these treatments, and I'll show you through some pictures in a little bit, through little tiny holes that we can make in the skin, and in this case we use the blood vessels to actually deliver the treatment. This is an alternative, and many of the things we do are alternatives to standard surgical therapy, and this is, in many of our procedures, is performed just with local anesthesia and some sedation. So if you remember at the beginning of the talk, I talked about how fibroids are very vascular, and you can see the picture here on the left. You see fibroids on the inside of the uterus here, and you see these little branches of blood vessels that actually feed the fibroids. So fibroids like to get a lot of blood, and the reason that there's all this blood going to it is what allows the fibroids to grow. And so how we do the procedure as interventional radiologists is we take a little catheter, which is a slender plastic tube, and we can put it through a tiny nick at the top of the leg into the artery, the femoral artery at that level, and then we take our catheter and we thread it into the blood vessels and then into the arteries that feed the fibroids, as over in here. And then we get the catheter right up to where the fibroids are. We can inject something called an embolic, which is where the word embolization comes from, which is to block something, block blood flow. And we inject that embolic into the blood vessel, and it floats into the arteries that feed the fibroids. And when we deliver it, it just stays there. And when we block the blood flow to the fibroids. Now those fibroids don't have any blood flow. And then what happens over here, as evidenced in our little cartoon drawing, is the fibroids shrink. And when they shrink, a lot of the symptoms, especially the bleeding, pain, and everything else, go away. So how do we do this? We need, we have to look inside the body, and here to the left is one of these tables. It's called an angiography suite, where basically there's a special X-ray camera that we can, the patient lies on the table here, and this X-ray camera can actually look into the body, and we can see what's inside the body and navigate our little catheters while looking on the screen, which shows what's happening inside the body. And here, a picture on the right is a picture of just doing just that, where we have this little catheter going in, and we're looking at the monitors while the pictures are being obtained by the live X-rays here. And when we want to see the blood vessels, we usually inject something called X-ray dye or contrast into the blood vessels, and this is demonstrating just that. The X-ray dye is injected through the catheter and it floats into the blood vessels, and here you have a large fibroid, and you see all these squiggly lines here. Those are the blood vessels that are floating around the fibroid, and you can see, like I said earlier, it's very vascular. And what we'll do is we'll navigate that catheter, and here, and this will come in a little later, this will be important because you'll see this is a very nice branch of the artery, and we can thread our catheter nicely into this artery, and then we deliver that embolic, or that agents that's going to block the fibroid. And here we have pictures of the embolic agents that we use to block the fibroid blood vessels. And these are calculated so that we know the exact size based on what we see when we inject the X-ray dye into the patient that we need to use in the patient. And they will be delivered through the catheter to block the blood flow. And what happens, generally for most patients, it's an overnight admission, it's an outpatient observation, they'll stay in the hospital overnight. We do give medications because there's frequently cramping after the procedure, and patients are kept very comfortable until the next morning. They're discharged and they go home just on some oral pain medications. And this here is a very typical picture of what we'll see on a patient who's had an MRI pre-procedure. This is a picture of the uterus outlined and a very large fibroid in here, and this 3 months after the procedure, you see how the uterus has not only shrunk down, but that fibroid has shrunk down. And here also you may be able to see we have a bladder that's totally compressed. That patient had urinary frequency, and now here's a bladder over here that's not compressed, and so the patient's urinary frequency also goes away, as in this case. And here also demonstrating after the embolization procedure that you see the arrow pointing to the 3 different fibroids there, and several months after the procedure, the fibroids are, as well as the uterus, are all shrunken down. So this is not a new procedure. Uterine fibroid embolization is something that interventional radiologists have been performing for the past 20 years. There's been a lot of extensive research on both the procedure, how to do the procedure, as well as the different agents or embolics that we use. And really everything we use related to this procedure is FDA approved and shown to be quite safe, and we've had some excellent long-term outcomes. So rather than dazzle everybody with all the different medical research that's been done, I compiled a slide here that really gives the whole story to patients, which is we see between an 85 and 90% short-term improvement or complete cure of symptoms related to fibroid after this procedure. When we look long-term, and we're able to say this now, over 80% of patients 7 years out from the procedure have success and have not had recurrence, and that number doesn't change too much at 10 years. We've seen that there's an equal quality of life improvement to hysterectomy in a lot of excellently done medical trials. And really there's been a lot of articles that have shown excellent success and safety, and for sure, because this is a minimally invasive procedure, a lower complication rate than most surgeries, certainly hysterectomy and myomectomy. So now we have to decide who's a candidate for this procedure. So of course we want to perform a patient evaluation. We want to make sure if we're doing this procedure that patients have symptoms, and then we're going to do some standard pre-procedure imaging, and that's typically with an ultrasound, although many patients when they're coming to see the interventional radiologist have already had an ultrasound, and frequently we'll get an MRI scan to get a better detail of the fibroids to make sure patients are candidate for the procedure. And here's a picture of 5 different examples of patients who've had MRI scans. These are all views from the side, and not that you need to know all the details here, but these are typical patients who are candidates for the uterine artery embolization procedure. There's an enlarged uterus, there's multiple fibroids contained within the uterus, and these are all patients who are candidates to have the procedure. And here's an example of a patient who had some very severe symptoms of pain, heavy bleeding, and we got the MRI scan, and what we see here is there's just this tiny, less than a centimeter uterine fibroid, and this really didn't correlate with the patient's symptoms, and so we know something else is causing the patient's symptoms, so we would not perform a uterine artery embolization on this patient. And then sometimes we're faced with patients who have uterine fibroids that, as in this case, are going up to the diaphragm, or as you see here, also going up to the top of the diaphragm, and sometimes we feel that these are just too big to do this procedure on. Sometimes fibroids will grow either completely, the only fibroid here within the uterus, or down here, here's the uterus, and this fibroid just goes completely out of the uterus, and we wouldn't generally perform the procedure on this patient as well. And sometimes the MRIs have what we call a very bizarre appearance, something that just doesn't look right, and we think that the patient should probably have surgery in this case. And sometimes they have a very suspicious looking case, although the incidence of cancer related to the uterus is very uncommon. It does happen, and we use the MRI to kind of tell us whether or not we think that's a possibility, and somebody like this would also be referred to surgery. So again, who's not a candidate? Either patients who have symptoms with either minimal or no fibroids, or if fibroids are what we call too large, too bizarre, or suspicious, then we refer the patients back to a gynecologist and generally for surgery. So now let me talk a little bit about a topic that people really want to find out a lot about, which is fibroids and fertility. One, is uterine fibroid embolization an option in these patients? Initially, when we started doing this about 20 years ago, the answer was unequivocally no. We didn't know what the procedure would do to future fertility, and we just shied away from even considering it. But what happened as we started seeing excellent results from patients with this procedure is we were getting patients from gynecologists who had high surgical risk, they had other medical problems, they had already had a myomectomy, and they had recurrent fibroids after the myomectomy, which can happen in about a third of patients, or the patient just was very against having a repeat surgery such as a myomectomy, or there were so many uterine fibroids that the gynecologist would tell us, look, if I go in to try and take out all those fibroids, I'm going to make Swiss cheese out of your uterus, and the likelihood of you getting pregnant, let alone me being able to take care of them, would be very low. So then we started offering the procedure in very careful and selected cases. Okay, so when we talk about options for patients who have fibroids, have symptomatic fibroids, and are also interested in future fertility, here are the 2 options. One is a myomectomy, as we've talked about, and then the other is actually a uterine fibroid embolization. So when I boil down the results from this data, we see that in all the different research trials that have been done with uterine fibroid embolization, there's about a 60% cumulative pregnancy rate after fibroid embolization, and that's actually very similar to the pregnancy rate in patients who've had myomectomy. The difference being is that the uterine fibroid embolization is a much less invasive procedure and definitely has a much shorter recovery time. And we've seen similar clinical outcomes. So patients who are having heavy bleeding or pain, when they have either procedure, they do get better. And as I just said, there's definitely a shorter recovery from the fibroid embolization procedure. We also see that there's a higher recurrence rate of uterine fibroids after the myomectomy. Now, we also have seen in these trials that there may be a slightly better reproductive outcome with the myomectomy, but if it is a repeat myomectomy, that's definitely not the case. And a lot of interventional radiologists out there, both in research papers and also, anecdotally, will report successful, viable, and healthy pregnancies after this procedure, and all of us who've been doing it for a while definitely have seen that. So what do we tell patients? We tell patients that if you have uterine fibroids and you have symptoms and you are interested in future fertility, we're going to individualize what's done. Not everybody is a candidate for a myomectomy, and not everybody is a candidate for fibroid embolization. So if patients have very few fibroids, they're very easily accessible for the surgeon to remove, then generally we will recommend a myomectomy. Certainly if there's a recurrence after surgery or multiple uterine fibroids that might be either difficult to resect or the patient is a high-risk patient, then we'll consider uterine fibroid embolization. And then there's a large number right in between these two, and after a lot of conversation with patients, we share the data, we share the experiences, we individualize what we're going to do for that patient. So now let me talk to you about what's new in uterine fibroid embolization, and we've been doing some very exciting work over the last year with robotic uterine fibroid embolization or robotically assisted uterine fibroid embolization. And so why consider robotic uterine fibroid embolization? Well, you know, as I showed you some of the pictures earlier, many times the procedure is very straightforward, and the anatomy is very simple, but we do see all different kinds of patients, and some patients can have a very complex vascular anatomy. In other words, how do we get the catheter into the uterine artery? And if that is complex, sometimes we'll need to use multiple catheters to get into those blood vessels. The procedure will potentially take longer, and when we do that, we'll also see increased radiation to the patient, our staff who are assisting us, as well as the physician. In addition, this can lead to technical failures where we're just unable to get into the artery, although that's very uncommon, it can happen. And sometimes we'll need to put a second catheter, typically not in just the one side of the leg, but we'll have to put a second catheter in the other leg, or bring patients back for a repeat procedure or another attempt. And here is an example of just that. Here's our catheter. You can see that outline here. It's sitting in the main artery before it branches into all these different arteries in the pelvis and the uterine artery. And here on the right, what this case was is the uterine artery made multiple loops. And so getting into this artery can be quite technically challenging. And here's just a picture from one of the companies that manufactures a whole host of catheters, and sometimes we have to try multiple catheters in order to get into the uterine artery. So let me introduce then the Magellan robotic system manufactured by Hansen Medical. And what is that? This is a robotic arm that is on the side of that table, and you can see it right here, the robotic arm. If you remember that picture I showed earlier of the room that we work in, it just attaches to the side of the table. And then we have a special catheter manufactured by the company, which goes into this arm, and the physician can either sit at a workstation or also work at a table-side control where they're controlling that catheter. The catheter doesn't just work on its own. The physician controls the catheter, and with this one catheter we can make multiple shapes. And here I'm going to show you a short video which shows the Magellan robotic catheter in action. So if you remember from the picture I showed earlier, we put the catheter in at the top of the one leg, and then we can navigate the catheter into the artery that feeds the uterus, and specifically the uterine fibroids. Now patients have arteries on both the right and the left. We deliver the catheter on this side into the right uterine artery, and then we inject our embolic agent to block the uterine fibroid, and we use the exact same catheter to navigate to the other side into the left uterine artery, and we just use this one catheter, and we could put different shapes on it where we're going to deliver the embolic agent into that left uterine artery, and once both arteries have been blocked, the uterine fibroid is going to die and then shrink. And here, just showing you here, is a picture where I'm sitting at the workstation controlling the catheter, and you can see here the table. We have staff that are attending, right, standing by the table, and I can actually use this workstation to drive that catheter into the uterine artery, and we're looking at live X-ray feed here. So here's one example. This is a 37-year-old female who had severe menorrhagia, which is heavy menstrual bleeding, dysmenorrhea, which is pain, and urinary frequency. And she had actually had a history of 2 prior myomectomy surgeries. So this is a picture from her MRI. Here is a very enlarged uterus with multiple uterine fibroids. You can see this white down here is the bladder, which is completely compressed by this. The fibroids are bordering this inside lining of the uterus, and that's probably causing the heavy bleeding. Here's the same patient, a view from the side. Here's the enlarged uterus and the uterine fibroids, and you can see here that bladder that's completely compressed. So we'll use the catheter, and here's just pictures from the catheter. We have an x-ray here of the pelvis. The patient is on the special angiography table where we're using live x-rays, and we put the catheter in the artery at the top of the leg here, and then we can navigate the catheter, and we know where the blood vessels are, and you can see this catheter coming down. In this case, it's coming into the left uterine artery. And then we inject the x-ray dye, and here we're going to see this very enlarged and twisty-turny uterine artery. We get our catheter directly into that uterine artery. We inject the x-ray dye, and this is the big blood vessels that are surrounding the uterine fibroid. And through that, we're going to inject the embolic agent until we've done that. And here are all these other normal arteries to the rest of the pelvis, but there's no more blood flow going into the uterine artery on that side. And then we retract the catheter into the right uterine artery, which is going to be down here, and we navigate that just like that. Into the right uterine artery, we inject the x-ray dye, confirm exactly where we are, and then we're going to finish the embolization. That catheter is going to come right out. And then we do a final picture to make sure that all the other blood vessels that we want to stay open are open, and the ones that are feeding this pelvis and the uterine fibroids specifically are now closed, and there's no blood flow going to that those multiple fibroids. So in summary, the use of the robotic catheter has actually allowed us to have increased predictability of getting into the uterine artery with just one catheter system. We have a lot of stability of the catheter for these procedures where when we put it where we want to have it, it stays. This minimizes the catheter exchanges in these very complex cases and therefore avoids technical failures in our ability to succeed at the procedure. And as I said earlier, although that's very uncommon, it can happen. And certainly one of the most exciting things for us is that we're decreasing radiation to the patient, our staff, as well as the physicians performing the procedure. And with that, I thank you very much.
Great. Well, thanks very much, Dr. Sterling, for answering those questions. And thank you also for all of your insights today and the information that you shared with us. This concludes today's presentation.